I'm Lauren Beal. I know a lot of you, but for those of you who haven't met, I'm one of the MedPeds attendings here. Dr. Suleiman, when I was talking to her about topics for my grand round, she has been on the wards a lot over the past few months and has had several young adults on her team. And when she's lucked out and had a MedPeds person with her, she's felt good about the plan for that patient. But there's obviously not as many of us as there are of the internists around, and so I think that for me the biggest problems I have at work and everywhere in my life are things that don't feel like they're in my wheelhouse, are very uncomfortable to deal with, and I tend to shy away from those things. So we're going to talk about this today, and I learned a lot doing this talk. Even though I'm in MedPeds, I still think we have a lot of ways we can improve our transitions here. We're going to talk about obstacles for transitioning patients from a pediatric model to an adult medical home and talk about it more from the internist point of view. There are tons of articles for pediatricians about transitioning patients, but I found looking at this there was not a lot for internal medicine out there yet. I don't have any disclosures or conflicts of interest to tell you about. And when I was thinking about this, the orders when I was a resident or when I've been an attending on medicine wards, the orders that I write or that the residents they're writing all the orders, let's face that, for an 18-year-old on medicine are not really that different than what I would write for a 17-year-old on peds, although there's some subtle little things. Your IV fluids may be a little bit different, even for the patient weighs the same the year before as they did that next year. So there's not, to me, any rhyme or reason to that sometimes other than habit. And things like giving oxygen to all the sickle cell patients, I think we do that on medicine, but they don't do that on peds. They tend to just have them all on a continuous pulse ox and kind of watch things. So why those differences are there are sometimes interesting to me, but something to think about. So ways that patients leave a pediatric practice, what we want is a coordinated transition that takes usually years to do. And I'm mostly talking about children with complex medical problems, not just well children. But ways that they leave out, they might age out of the practice. So the peds clinic may say, at your 18th birthday, we're not seeing you anymore. They may drop out, and lots of our type 1 diabetics especially, or people with different chronic medical conditions as teenagers will just kind of stop doing what they're supposed to and stop showing up, and then they come back into adult care when they turn up pregnant or something else that forces them to go to the doctor. They're forced out because they lose their insurance, and Medicaid for the most part will take care of you until you're 19, in some cases longer than that, but just depends. They move out and they change providers, or they kind of hang out, and we had patients on the peds wards when I was a resident that were in their 20s who had multiple sickle cell patients who had multiple strokes and really felt like they should be on medicine to me, but I could take care of them on peds because I was med peds. I didn't think that the pediatricians probably felt as comfortable with that. And the subspecialists would just kind of hang on to them for a long time. But what we want them to do is transfer out with a coordinated transition of care. So I'll tell you about this little patient. He's 21, he has sickle cell, diagnosed in early infancy. He was followed by a primary care doctor, and his pediatric hematologist had multiple pain crises that are less frequent now, occasionally treated in the ER or admitted, but mostly treated as an outpatient. Consistently got appropriate medications, immunizations, and in-organ monitoring for his sickle cell. And then you fast forward to when he's 25, and you have the ideal scenario where he's followed by an adult primary care doctor and an adult hematologist. He is still getting managed mostly by his doctors as an outpatient, and sometimes has to go to the ER and get admitted and gets all his appropriate sickle cell care. Or he doesn't have any, and he's just going into the ER here and there and still trying to contact his pediatric hematologist, and then going to the ER and getting accused of pain med seeking, and doesn't get all the appropriate preventive care that he needs. So what makes the difference between those two things? And I think that if you wait until, what happens a lot of times, patients are seen and they're 17 and a half, and the next follow-up they're due to go to somebody else. That is how we are moving patients into medicine here, instead of a years-long preparation for these patients. So transition is the purposeful, planned movement of adolescents and young adults with chronic physical and medical conditions from a child-centered to an adult-oriented healthcare system. We've known that for a long time. It's a dynamic, lifelong process that seeks to meet individual needs as they move from childhood to adulthood. It's patient-centered, and its cornerstones are flexibility, responsiveness, continuity, comprehensiveness, and coordination. You have to think about the capacity of each adolescent. So there are some people that are 18 that have some developmental delay that are not that age, and you can't have the same talk with them about, if you don't control your diabetes, you're going to end up on dialysis, because those long-term consequences are not in there. They're not developmentally ready to hear that kind of talk. You have to tailor it to their developmental age. So you may hang on to those patients longer. Transfer, on the other hand, is what you see a lot of times. You may have a patient get admitted to your ward team who's had miles and miles of notes in Epic and lots of complicated stuff, and the first time that they show up on medicine is when you admit them. And that is not good. That's not fair to you. It's not fair to the patient. So it really should not be the way that we do things, if we can at all prevent it. So here, pediatrics stops when you're at your 18th birthday, and some of the pediatric subspecialists will still hang on to patients longer than that, sometimes through age 21, sometimes longer. It just kind of depends. Sometimes they'll let go of them earlier than that, or at least to be admitted to the peds floor, you can't have, or at least for some of the rules for the peds floor for pediatric subspecialists, you can't have been pregnant or done some other things, been incarcerated, things like that, to be on the peds floor. There are certain circumstances that I think it is really appropriate to hang on to patients. If you have someone who is transitioning to hospice and they're in that age range, then it's probably not a good idea to just move them to a new doctor right then. And we've had patients like that I think it's more appropriate for the person who's taken care of them their whole lives to help them with end-of-life issues, rather than say, here you go, internist, they're 18 now and dying any day now. I don't think that's fair to you or to the patient, and it's not how I would want my family members treated. So there are certain times that I think it's appropriate for us to let them stay on pediatrics and give them some continuity, especially when there's end-of-life issues. If you think about young adults, even the healthy ones they're most likely to have morbidity and mortality from accidental causes and ATV accidents and things like that. So they have the highest rates of motor vehicle injury, death, homicide, mental health problems, sexually transmitted infections, and substance abuse, but really poor health coverage. And so they're kind of in this perfect storm. So I'm mostly today talking about more complex transition. It's pretty easy to, at your well visits, I do this when I see patients starting at their 12-year-old well visit. I have a part of the visit where the parents are in the room, and then I say, this is when you start having time with me on your own, where everything is confidential, except if you tell me you're being abused or you want to kill yourself. And then I have to tell your parents that. Other things that you tell me that I think would be a good idea to share with your parents, I will help you figure out a way to do that, and we'll do that together. But I start that early on, and so even well kids, as they go on, they've had several visits where they've had to tell me their medicines or tell me what they're up to, and it's not just for secret stuff that they don't want to share with their parents. It's the idea is you have to learn how to make your own appointments. You have to learn how to take your medicines, set alarms on your phone. You have to start doing those things now. But especially people with complex problems, you want to start that transition process no later than age 14. So you'll hear a lot about youth with special health care needs. That's not really a term that I've ever seen an internist write or say, but those are kind of the patients that are at increased risk for chronic physical, developmental, behavioral or emotional issue that's kind of above and beyond what most children or young adults need. So some of the conditions to think about: asthma, ADHD, diabetes, sickle cell, and there's a list here you can see. But a lot of these are things that you didn't probably choose internal medicine to take care of. And you're not going to have so much of a choice as we have more and more of these patients surviving into a later adulthood. So transition is important. If you fail to recognize and plan a transition, you can have your patients drop out of care and have them have poor outcomes. Poor transition processes are recognized to have a significant effect on morbidity and mortality in young adults with chronic health needs, especially for preventable things. I think it's tragic to miss the opportunity to take care of those things. You can't do much about patients that are not going to comply with your treatment plan, but if you start them from the get-go and make them feel confident and empowered to take care of their own stuff, they're much more likely to try to stick with that attitude. So if you had sickle cell in the 70s, your life expectancy was very different from what it is now. Same thing with cystic fibrosis. If you were in the 50s, you didn't make it past the first year of life. And our life expectancy now is in the 40s. It's even higher in Canada. The US is actually 10 years lower than what people in Canada have for cystic fibrosis, which to me is sad, but a lot of that has to do with how often and how early we refer for lung transplants and healthcare coverage and things like that. So that's part of the triumph of medicine, is that we've enabled over 90% of these chronically ill children to make it past their 20th birthday. In the 70s, if you had spina bifida, you were lucky to make it beyond age 20, and then in the 2000s, over 80% make it. And then, like I said, with CF into their 40s right now, in this current birth cohort into their 50s. And then HIV, you're expecting to see some of these kids that have HIV as a kid, they're going to live a long time, and you may have different things to think about with those patients than you do with an adult who was diagnosed with it. So there are 500,000 children with special health care needs that turn 18 every year. So obviously there are way fewer med-peds people in the world than there are internists, and then there are family medicine doctors also that will meet these needs, but it's definitely something that you're not going to be able to hide from. Think about things that teenagers on their best days are doing. They're separating from their family. They're working on a healthy self-image. They're trying to meet educational goals, become independent financially, live independently, maybe find a partner or get married, and then be happy and have their mental health intact. And then you take those teenagers and then add a chronic illness, and a lot of those things become a lot more complicated. Most teenagers don't have to cope with their own mortality at that age, and so that's something that if you're not comfortable dealing with, you're going to want to try to find resources to help you with that. So there are barriers to successful transitions from the pediatrician's point of view, from the patient's point of view, from the internist's point of view, and system-wide there are barriers in our system, but I want to talk about mostly from the internal medicine point of view. For a family, they may have difficulty finding an adult healthcare provider who is knowledgeable about their condition. If you are an adult cardiologist, your fellowship gives you about 6 hours of training in congenital heart disease. So transitioning from a pediatric cardiologist to an adult cardiologist, they all are going to have variable amounts of actual training and experience with those patients. So you're going to have to try to find, you're not lucky enough to find a person who's really got a lot of experience with that in one of these adults with congenital heart disease clinics that are popping up all over the country. You might have a hard time finding that. There are practice differences, and this is by no way to say that internists cannot be nurturing and warm, but that you have to accept that there are going to be some differences in the clinic atmosphere moving from a pediatric model to an adult model. If they've been with this clinician their whole life and they diagnose them at a young age with leukemia and then they've been following them for years, it's hard to let that go. This is the person that saved their child's life and has been there with them through thick and thin, and to move away from that can sometimes be really hard for both the pediatrician and the patient. They may lose their insurance like we talked about, and then they may not have good perceptions about adult-oriented care. So these are generalizations and not meant to be offensive at all if anybody gets sad about it. In general, adult providers are going to value autonomy more. They're going to be more looking at the individual than the family. They're going to focus more on the disease and not necessarily always the social setting. They value respect over warmth, and they can view pediatric care as smothering, which sometimes it can be. So you're looking at people that are having to change their whole way that they look at going to the doctor. From the pediatrician's point of view, they may want to transition their patients and they just are not able to find adult providers that can and will accept their patients. They may meet resistance from the patients and their families. They may not have really a lot of time to dedicate to transition. These are not quick notes to write or quick things to do. They take a lot of coordination and resources and personnel, which we don't usually have. They may not get reimbursement for the time they spend on these, and then be pressured to keep doing other things that generate revenue. And then they may have a reluctance to give up their relationship with the child and their family also. For an internist point of view, you may just have not had enough training in certain congenital or childhood chronic conditions to feel like you're comfortable with managing those patients. You may be worried that the family is going to drop out and not stay involved, and you actually do want them involved as a resource for that patient and help for you. It may be difficult to meet the psychosocial needs of young adults, especially those with chronic illness. You may have to be doing a lot of coordination for subspecialty care for those patients. I never have seen any of us on medicine do rotation in adolescent medicine, but you're not tending to get a lot of training in that unless you look for it. And then they may not want to deal with these young people that are facing end-of-life decisions, and that may be something that made you steer away from pediatrics because you didn't like that, and you were much more comfortable with treating an 87-year-old at the end of their life than an 18-year-old. So there are, like I said, there are lots of transition clinics and adults with congenital heart disease and all of these things popping up over the country to try and meet some of these needs of these patients. So we don't live in a place that has that right now, so we're going to work it out a different way. We talked about this. We're going to keep going. And then, like we said, lots of these patients are surviving well into their adulthood now. So the goal of transition is to maximize lifelong functioning and potential through high quality, developmentally appropriate healthcare services that continue uninterrupted. And to me, this is always nice to see when these multiple organizations from different angles get together and try to solve a problem. It just makes me happy, especially when people smarter than me are in charge of figuring out how to do that. We have all these goals that people come out with, and there was the Healthy People 2020 and made these goals that we are going to increase the percent of children with special health care needs who receive care in a family-centered, comprehensive, coordinated system and have access to a medical home, and they come up with these lofty goals, and then not much has really changed since there was one statement in 2003 and another one in 2011, I think, and not really anything made a whole big leap between those two statements. So I'm going to keep going because some of these are redundant. There is, I think, a difference in, and I've heard lots of people say this, and I may be guilty of it on peds too, of coddling patients, and then when they get to internal medicine, the internists are saying, what did those pediatricians do to you, and where did you get the idea that we were going to do all these things? But there is a different perception if you see a child in pain. I'm almost never going to question their motives, and I'm going to treat their pain. As opposed to an adult, you really have, especially if you've been burned in the past, you're going to be a lot more skeptical and have a hard time treating such a subjective thing. Let me keep going. Okay, so I wanted to talk about, there are a couple of articles that I thought were helpful, and this one was from Pediatrics, and it was a survey that was sent out to a bunch of internists to see what their issues were with transitioning kids into their practice and what their main concerns were. So they mailed out this survey over a few years and asked, in the first stage they asked their concerns, and in the second stage they asked them to rate those concerns on a scale of how much it impacted their ability to care for a patient. So I am no statistician, and I'm not going to pretend, but the big red box at the top with all the ones on the little Wilcoxon rank were the top things, and that's all I'm going to try to say about that, and those are the ones that are important to you. So I have separated them out here so you don't have to try to read that terrible slide. So their number one, internists may not have the training, like I said. It's difficult to care for patients if their family doesn't stay involved. They may need a specialist. It's basically all those things that I said earlier that are actually the concerns that internists have come up with. So you want to feel like you are able to do this, but I think that sometimes our system is not really set up to help you succeed with that, and you can't control what has happened for 18 years in a pediatric practice. Once you get that patient, it's done. Okay, I'm gonna keep going. Okay, so what in these talks, I think it's helpful to actually see what should this actually look like and what should you expect to receive from a pediatrician. There are so many giant documents on this gottransition.org and checklists and steps and all this stuff that I think can be kind of overwhelming. But if you think about the same thing, if you have a patient in the MICU for 9 months, you're not going to send them out to the floor with no substance about what has happened over that time period and a long-term plan for that patient, because you have been taking, or not you necessarily, but that unit has been taking care of that patient for that long. So if you think about what you would need to take care of that patient for long-term, at least for the next couple of weeks while they're still in the hospital, and then beyond that, that's what you really want to see in a transition plan. What do you need to do to help that patient stay in the system? What do you need to take care of in the long term for them? And this is basically just looking at the patient by age and where they are in the steps of the transition process. So we're going to talk about it. There's 6 steps. One is to have an adult transition and care policy. The second one is to have a registry where you track and monitor those patients. Then you are assessing their transition readiness and kind of orienting them to an adult practice, then planning and integrating them into adult practice. Then they have their first visit with an internist, and then their transition is complete, but you can still talk to the pediatrician when you need to hear about things and ask them questions like, where did you get this regimen for their medicine? Where did this feeding regimen come for their tube feedings? So the first things on your clinic policies: what age will you start seeing patients? Do you have a policy for accepting patients? Do you say, I'm not going to accept anyone unless they have this packet of information with them? Or what are your rules? What are your privacy and consent policies? And then educating your staff about how you're going to approach these patients. So this is just an example one from Colorado, and it says, we welcome youth and young adults with chronic pediatric healthcare needs. We provide care for all our patients 18 and older, blah, 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 blah. And it's just kind of a general, like, here's the welcome, we're happy to help you, this is what we expect. And then this registry, it's just to help you keep track of the patients that are in your practice and up through when they turn 26, so you can say where they are in the process and if you've gotten all the documentation you need from them, and kind of whether they're meeting all those 6 steps. There are places that have this available in their EHR. I have no idea. I haven't even looked into that for Epic to see if that's an option here, but if it's smart enough, and it's probably is, then you'd be able to do that. So this is an example of what that might look like. And then you're rating how complex they are, if you've communicated with their pediatrician and all those things. The PEDS team, from their end, they're supposed to be visiting with the parents in the room and then without the parents in the room. I'm working on some self-management skills. There is this transition readiness assessment questionnaire, and it's basically 3 statements that they can say, yes, I know how to make appointments, no, I'm not sure, and I'm going to need somebody else to do that. Or yes, I know how to take care of my medicines, I think I might, or no, somebody else is going to have to help me do that. And that just depends on their physical and mental developmental ability. Sometimes they really are not going to be able to do all those things themselves. So this is an example of that transition readiness assessment questionnaire. And to me, these are some of the things that we don't think about, and they're not, I just kind of figure everybody's got good families like I do, and they're helping me figure out how to live my life and grow up and be a successful adult, but not everybody has that. So asking them questions like, do you fill a prescription if you need to? I don't need that. No, I don't know how. No, I don't know how, but I want to learn. These are very practical things to ask people and get them to start thinking about years before you send them to the internist. And for your side of things, you're going to do what I was saying earlier, and you're going to orient them to the adult side. They may want to come. You may want to provide some online or written information that they can use. You may want to have kind of a get acquainted visit so they can come and meet you and see that you're not a troll and that you are a good doctor and you are there to help them. I think that would make a lot of people more comfortable, and even just to go visit the non-5th floor and see that the rest of the hospital, even though it doesn't have crayons, it's pretty similar, although it smells different. It smells like, well, okay. Excuse me. So the pediatricians, aside from that healthcare transition checklist thing for the patients, they should have a portable health summary and an emergency plan. And so a lot of the endocrine doctors will have this. This person is on long-term steroids. This is what you should do if they come in and they look sick. Or the neurologist will have a seizure plan. If this person has a seizure, please do not do a CAT scan of their head unless you're worried that they have a bleed in their head. These are the things you can do in an emergency. And those are good things for patients to have with them so that they don't get 50 jillion CAT scans every time they have a seizure and go to the ER. Or they get stress dose steroids when they're supposed to, and Raj will not be sad. So this is what one of the medical summaries can look like, and then there's obviously more to it, but I didn't put the whole thing. You want to communicate with pediatric providers. I think that we do okay with this sometimes. I know that our PEDS GI attending goes to the GI conferences on Thursdays. Our endocrine people, I think, do the PEDS people come to your stuff? Sometimes. The ID people all have their little club. We hang out with Dr. Bocchini and Dr. Vancheri and all that. Yeah. So I think that those types of meetings and having kind of a, hey, this patient is coming your way, those are good times for the subspecialists at least to talk. We don't have a general medicine hang out with the general pediatricians kind of club as far as I have known, but it would probably be too big to try to do that. But communicating with the pediatric providers and getting those documents from them is what you want to look for. And then if you identify that a patient's going to need home health or other things when they come to internal medicine, you can help them figure out where to get those resources. And then if you don't know what those resources are, then ask one of your attendings or ask one of the case managers. Most of the patients are going to transfer at 18 here. Think about, like I said, if their illness is terminal, if they're not medically stable, you may want to hold on. Has their readiness for transition been assessed, and what skills are they going to need? At that initial visit, so this is the 5th step, you're going to address concerns from the young adult themselves, herself. You can assess that transition readiness questionnaire if you don't feel like that's been done. There's nothing wrong with you trying to figure it out yourself and see where that patient is in their process. This is one of the examples of the transition flow sheets. So I don't know that some of these are very practical for you to contact the young adult before the first visit to welcome them and answer their questions. But if you were in a transition clinic and you have the personnel, then there may be somebody that calls and says, "Hi, we are anticipating your visit and we want to make sure you know where the building is," and things like that. And then looking to see if they've gotten all the documentation from the pediatric provider that you're looking for. So somebody's already done that before the patient even sees you. And then when transition is complete, the pediatric primary care doctor and team remains a resource for the adult side. Okay, so what do we need here to make this better? One is better education and training on both sides for pediatrics and internal medicine on planning and implementing a transition and making sure that patients get what they need before they get to you, so that you don't have somebody pop up on your ward team or they get admitted to the step-down unit ICU with DK, and that's the first time medicine ever sees them. If you ever wanted to do an adolescent rotation, I'm the one in charge of that on PED, so you could talk to Dr. Suleiman and see if she would approve that, which I'm be more than happy to help y'all with that. Better training for issues related to insurance, guardianship, and billing. And then there are so many disease-specific things related to transition. So you could do this for GI, you could do this for ID, you could do this for lots of subspecialties. And then having more available in adult journals with regard to how you handle this. So this is one of the things that I've been trying to, I've tried for a couple of years to get someone to do adult survivors of pediatric cancers for MedPeds grand rounds, because I think that I've been lucky that I had one patient who's had rhabdomyosarcoma as a kid, and she has this beautiful document from St. Jude that says basically a lifelong anticipatory thing for what I need to look out for her, and kind of a long-term plan for her. And I think that has made her care a lot better, and I'm able to handle that, and I feel like I have good resources to do that. And if I ever have a question that's not on there, it's easy for me to find that information. If you are a resident here and you haven't done your PEAK modules, or you want to do more of them, there is one on adolescent medicine. I did it the other day. It's got a good introduction to adolescent healthcare and developmental stages for adolescents and things like that. We have that adolescent rotation. Our pediatric subspecialists, I think, are very approachable. I've never had any of them get too fussy for me walking into their office and asking them a question. So if you have a patient that you're taking care of in clinic and you haven't gotten them to the subspecialists that are appropriate for them yet, you can always talk to the peds people and ask them. If you have a med peds person on your team and you have a 19-year-old that you think would be a great patient for them to see in clinic, and they agree, then that's a good, that's a perfect little niche for a med peds person. And you do some internal transitioning. Even when I'm seeing a patient and I see them as a 17-year-old, I've been transitioning them the whole time I'm seeing them, so that I am ready to say, when you turn 18, your mom or dad or whoever is not going to have to come with you to your visits, because we'll have already been doing this for years. And then Med Peds Grand Rounds, I do try to find topics that are going to relate to this, to adolescent healthcare and transition. I'm not always successful, but I try. One thing that I found out of all of this that I thought was amazing is the ACP has condition-specific tools and checklists under each subspecialty. So there's one for general medicine that's adults with developmental delay, I forgot how it's worded. Anyway, and then there's one for inflammatory bowel disease for GI. There's one for diabetics, type 1 diabetics, and it's a checklist and kind of a long-term plan. Why do the lights look weird? Yeah. Okay. Either me and my vision, I need to go to get an MRI, or there's something else going on. But this I thought was excellent, and I think to me it looks like all of these major organizations are getting together and finally saying, hey, we've been telling these pediatricians how to transition patients for years, but we never actually talked to our adult friends to make sure that they understood what they're supposed to do when these patients get there. So if you go to ACP and look for under resources for clinicians, there's this ACP Pediatric to Adult Care Transitions Initiative, and there's lots of great resources there. I looked at if this is too foofy for you and you don't care at all, at least it is a few questions on your medicine board, so you want to try to pay attention. I know the ITE this year had an Osgood Schlatter and had a couple of teenagery kind of questions, so it is something that they're expecting you to know as an internist for people that are way fancier than I am. It would be really easy to make a good QI project out of this and just to even pick one of those handoff sheets on the ACP website and start incorporating it into Epic somehow and show that we're transitioning all our type 1 diabetics and improving their health care in some way. I think that would be easy. These are billable services, and I'm not going to go into all that, but there are billing codes for you transitioning patients if you wanted to figure all that out. And then there are a bunch of online resources. There's this Jack's Hats program in Jacksonville. They have a bunch of transition documents and things you can download for free. That gottransition.org also has the same thing, and you can do it from a med peds person transitioning a patient within your practice. You can do it from the internist point of view, and it has the 6 steps kind of tailored to each practice. And then I put a couple other resources on there. Thank you, and I also want to thank Dr. Taub, who had some of these slides that I used and gave me permission to use a few of them in my talk and saved my life. Anybody have any questions?
Does Baylor or St. Jude, do they have nurse navigators or social work navigators? I mean, the culture of...
Baylor has an amazing transition clinic that I've heard a lot about, and actually one of our students did an away rotation there a couple years ago, and she said it was amazing. And she went into medicine, but she still loved that. And I imagine their resources are way different than ours, though.
It just seems like some extenders could help, because the culture of healthcare and pediatrics is very different from a patient and parent's perspective.
Oh, now you're really going to sleep. If you had a multidisciplinary clinic with a social worker, a dietitian, a counselor and a psychiatrist would not hurt to have around too. I mean, those clinics, I haven't been able to really, even though I didn't talk about that, there is an ambulatory referral to adolescent health that I've created an Epic, or had created an Epic, so that the peds people could send referrals to that, and I could get them into med peds clinic that way. And some of them use them. I've probably had 30 or 40 referrals over the past few years total. And so a lot of times they're 17-year-olds that are going to turn 18 by the time we need to see them, though, and that's the first time we're hearing to transition them. But that is something y'all can use if you're needing to refer a teenager. It's basically med peds clinic, and then I have the residents that are on their adolescent rotation come to it. So it's been hard to get all of these people into one place and create even something that looks remotely like a transition clinic. Any other questions? Thank y'all so much.